Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. 25 years ago in Rwanda, a man handed Dr. Evans, who is our guest today, a small truck built entirely from popsicle sticks. Glued carefully to the side was a logo, the white on red emblem of Doctors Without Borders. It was just less than a decade after the genocide for this man in Rwanda, but it was proof that help had arrived and proof that help could be trusted. That's the key word. That image stayed with Dr. Evans for a quarter century, and it points to straight at the question running underneath today's conversation. How do you earn trust from communities that have every reason to withhold it? I feel like there could be a whole podcast series on trust in healthcare, but today we have one episode looking at it through one lens. Dr. Evans trained in infectious diseases and addiction medicine, then spent years in places most clinicians never work. South Sudan, Central African Republic, 2 Ebola responses across Sierra Leone and the Democratic Republic of Congo. Then his work moved closer to home as the chief medical officer for New York City's COVID operations in 2020. Talk about a big job. Then he moved to mass immunization sites across the Bay Area through a company that delivered more than 2 million vaccines in 10 states. And today he leads Wellness Equity Alliance and written a book called Pandemics, Poverty, and Politics, published by the Johns Hopkins University Press. In this episode, Dr. Evans gets specific about how trust actually gets built. You'll hear the small, concrete things he does before a patient says a word. Hopefully, if you've listened to most of the episodes, this all sounds familiar to you. Reading patients' social history closely, learning whether their language is Urdu or Tigrinya rather than logging quote-unquote non-English, leaving the white coat in his office, and walking in with the greeting in someone's own language. As I said, if you're listening, maybe you're a pro at this and you're doing all of this, but this is a good reminder that these small things, even in the context that I mentioned, goes a long way. We'll talk about a concept he calls humanitarian entrepreneurship, pulling tech, pharma, and finance into the same room as clinicians. Part of this podcast, I talk about how to move systems to address the problems that you're witnessing, because there's daily things that you can do to take care of your patients better. And there are systemic things that needs to change. And he's been finding the intersection of both of those areas. As he says in this episode, wellness shouldn't have a proprietary connection to those who are privileged. So part of this is, how do you hand all those tools that we know are available to the communities that have been kept furthest from them? Here's Dr. Evans. All right. Dr. Evans, nice to have you on the podcast.
Great to be here.
Tell me briefly about yourself and your organization that you're leading.
So trained in adult infectious diseases and addiction medicine, and in a number of different spaces throughout my career. Spent many years working in the global south, so low and middle income countries, places like South Sudan, Central African Republic. Worked on the Ebola response twice in both Sierra Leone and Democratic Republic of Congo. So war zones, complex humanitarian emergencies, I've always been moth to a flame. And in the global north space, or the US, most of my work has been in HIV and everything that sort of connects to HIV. We're increasingly referring to this as syndemics, basically epidemics that work synergistically with one another. They don't have to be infectious in nature, but just amplify the ultimate sort of outcome. Addiction or behavioral health is often one, and poverty, the social drivers, are the big one. So spent many years in a number of different areas. South Sudan, South Bronx, South LA. I have a theory on the Souths. And then ultimately just been in the foxholes for a long time. And as my career advanced and my leadership took on different dimensions, I started treating more of the systems rather than the individual patients. I still see patients. But so that basically evolved into, I was chief medical officer for New York City, overseeing COVID operations in 2020. So that was obviously a big job. And then went back to California to stand up mass immunizations in the Bay Area. And then I found an opportunity to jump into the private sector, where we formed an organization called Curative. And we administered over 2 million COVID vaccines in 10 states, did over 1 million in California. And we're able to see the arc of possibility of a physician or clinician-led organization where we could really focus on what mattered, we believe mattered, which was operational efficiency as well as health equity. And so that balance is not often seen. And when you have administrators that are not in the foxholes, treating patients, treating the sickest possible patients, they just don't get it, right? It's basically, it's Excel sheets, it's balancing budgets, which we do need to do. And that was a new sort of skill set that I never thought I'd find myself jumping into, but it makes me a better, more effective leader to understand the funding. So anyways, I was really proud of that work. We got invited to the White House to talk about our work, particularly in the southern border of Texas, and really, again, balancing the needs of scaling, but scaling with an equity-centric sort of model. And so then we formed Wellness Equity Alliance about 5 years ago with that same intent, but it was less of like surge provider, which was more of what Curative was, and is more kind of blue skies operations. How do we partner with existing institutions where there's tons of gaps? Not anybody's fault, right? It just existed that way, or it's evolved that way. And it's getting worse, right? Because of the political reasons that we're faced with now, which are further getting amplified. So Wellness Equity Alliance basically is that sort of connective tissue working in between existing healthcare systems. So those are safety net hospitals, FQHCs, managed care plans, public health departments, and trying to find where we could concretely provide an operational response and help fill in some of those gaps, which again, continue to widen, particularly widen during infectious disease outbreaks or pandemics. So street medicine is again, a concrete representation of that. And our street medicine operations mostly down in Southern California, integrate primary care with behavioral health. We define behavioral health as mental health or psychiatry, as well as addiction medicine or substance use disorder treatment and prevention. And then importantly, infectious disease treatment and prevention. So big focus on HIV. We're focusing a lot on long-acting injectables now for HIV prevention, as well as community health workers. So really integrating those three for the unsheltered, unhoused, in places like Southern California, particularly Los Angeles, that has the largest homeless population, unsheltered homeless population in the continent, is a concrete version of what we're doing. But we have other operations where we exist and where we're further growing or scaling. Our strategic initiatives outside of HIV street medicine are tribal health, rural health, behavioral health, and of course, public health.
I love it. And it's not often you hear this focus on health equity. Number one, it's become not cool to talk about health equity these days. But actually also originally thinking about both operational efficiency and health equity. I think that intersection's rare because I didn't tell you my background, but I also have a leadership role in our institution and do some health equity work. And I think so much is probably based on, obviously, your experience, as you said, in the foxhole, witnessing suffering and realizing what does health equity actually mean and why that's an integral part of healthcare and everything we do. Think of Paul Farmer, right? So much of his drive was because of that. The transition that I want to make is what compelled you to write Pandemics, Poverty, and Politics?
Marrying between the operational efficiency and health equity. And that also includes the finance piece as well, right? Like at this point, I think a lot of the safety net hospitals, the federally qualified health centers have emerged as super important, right? Super important to respond or prevent a lot of disease. The reason why we incorporated our name as Wellness Equity Alliance and not Health Equity Alliance is because we need to go beyond, right? Wellness, this concept is often correlated with chia seeds, yoga mats, and suburban moms in strip malls, right? But it's got to be more than that. And it can be, it's that other dimension of health and wellness. It's the spiritual, it's the mental health, it's behavioral health. It is ultimately just, again, living well and not focused on disease prevention or the prevention of further advancement of health outcomes. But yes, the concept of health equity, and yes, has now become a sort of dirty word in a number of spaces. Not for us. We're gonna continue this because it's a marathon, not a race. But health equity, a lot of times, especially under the Biden administration, was increased. And I think partly because it wasn't just political, it was partly because of all of the results that we saw with COVID-19 pandemic. We knew that the most historically marginalized or the most vulnerable, not the same thing, were the ones that were getting the most impacted ultimately. And so we needed to change things around. But what happened was a lot of people just started talking about health equity. Some of it was PR, some of it was real. But the folks that were focused more on the health equity It was a lot of the feel good stuff. And I love those clinicians. I'm one of those. You can't just do some fun stuff and focus on some equitable sort of components or even get serious. And I don't mean to be dismissive about that sort of group, but the folks that are really focusing on the operational efficiency, the systems folks, right? The health systems folks, like it's got to be sound. It's got to be effective. You've got to see a lot of patients, and it's partly revenue, but it's access. Like equity is a lot about access, and the more operationally efficient you are, the more patients you're ultimately going to see. But it's not the FQHC model, which is, I think, again, love the folks that sort of built the FQHC concept and everything around it. But there's something deeply ineffective about that model. For people who have worked in FQHCs, including myself, I've worked as a provider and as a leader in fairly qualified health centers, and having that provider productivity, seeing a patient every 15 minutes, et cetera, that are deeply sick or whatnot, that does not work, right? So really understanding how do we provide appropriate care, but that's operationally efficient and is generating enough revenue so that we can do more, right? That's a really important question to answer. And that's what we're constantly thinking about at Wellness Equity Alliance.
You're speaking my love language. I love this. As I said, not a lot of people in that space. And I think it's really important because I do think when we were really focusing on health equity, sometimes we were thinking about stories and flashy projects that can capture attention without that operational efficiency. And some might say the boring stuff to sustain something that's truly focused on health equity. So I admire that. I want to follow another thread of just what you said on wellness versus health, because so much of maybe the distrust from people that I hear from about healthcare, part of it's financial, but actually a deeper part of it is this biomedical model that we say in healthcare and based on pharmaceuticals. And you alluded to that with the community health center, but I think it's all healthcare organizations. So they don't really care about my wellness. And I could say, no, I do care about preventive care of you not getting diabetes, not getting heart attacks. They're like, not getting something is not wellness. But I actually want to feel like I'm living, I don't know, quote unquote, my best life spiritually, mentally, and if there's a positive aspect to it. And we're so much on the defense of protecting people from illnesses and getting this threshold. Do you feel like we're making progress? Because it feels like we haven't quite found a way there with healthcare institutions. Not sure if you're seeing any bright spots or seeing anything different.
The short answer is no. It's like net sum. I don't think we have. I think in fact, we're going backwards today on November 17th, 2025. But I do think, I'm an eternal optimist. I do think we will get there, but it's got to take some more groundbreaking brainstorming. We got to look at these things differently, right? And we have to, I'm really pushing or advocating for this concept called humanitarian entrepreneurship, where we could, because we've heard about this term social entrepreneurship, where I don't know how I can define it because I don't fully understand it, because social entrepreneurship's really big. It's a really big sort of concept, which I know a lot of folks working in that space mean well, but I just don't fully understand it because, again, it's just too big. Whittling down that concept, what makes sense to me in my world as a medical humanitarian is to inspire and incentivize different thought leaders in different spaces coming together to solve a problem that we can actually be profitable and to provide more access and more opportunities for folks so that we can really get to that wellness piece for some of the most historically marginalized communities. Because I don't think that wellness as a concept should have a proprietary connection to those that are privileged. I think some of the most historically marginalized, if we can give them the tools to go above and beyond the disease prevention model and take control and not empower, because that is a distorted concept, but power share with these folks that they really rise above where they are and really give them the tools. And a lot of that is education, health literacy, et cetera. So it's going to be a lot of work, but I do think that if we can get some of the smartest folks together, and it's not just healthcare professionals, that's tech, that's pharma, that's finance, getting these folks together and really thinking through models that, again, can scale profits and make people feel healthier and well, I think we've got something. And there are examples of that. So anyways, yes, I think we will get there, but it's going to take different a way to get there. I'm going to get to your questions. Why did I write the book? What was there some inflection point? The book had been so that's Pandemics, Poverty, and Politics, putting the social and political drivers of pandemics from plague to COVID-19. This has been a book partly in my mind, partly I had started scribing for decades. I started working in the HIV space in the late 90s when I was still a student. And so I started penning some of these ideas back then. I've often identified myself more of a writer than a doctor. And I always needed that moment to really just synthesize everything and get it out. But as a doc and as a physician leader and as a father of 2 COVIDians and 4 humans, it's been hard to find time. And that's any physician or healthcare professional that wants to write a book or do anything really big, tangible, you got to carve time and you got to make it happen, but you've got to structure that time. But it had been rolling in my head for decades, literally being in the foxholes of refugee camps, war zones, complex humanitarian emergencies, and then connecting that to working in FQHCs in the South Bronx or other areas now focusing on street medicine. The conditions were substantially different, but the drivers, the determinants were very much the same. So anyways, collecting all of these stories and narratives and then putting them on paper and then starting to connect these ideas. And the pandemic really was the accelerator. The COVID-19 pandemic was the accelerator to get the concept idea out to folks because, man, every time we've seen this, I've been on the front lines of Ebola. I've been working on HIV my entire life. And then we hit COVID-19 pandemic. And of course, I've seen TB, malaria, a lot of these other things. But we've got to start changing the way in which we are addressing these because we are going to continue to see further COVIDs or related diseases. And almost the concept of the book is really trying to share with not necessarily healthcare professionals, but even lay audiences, which is why I really tried to minimize the complexity of a lot of the medical speak that we use in medicine, right? All these unnecessary words and terms to make us feel smarter. We dress up in our costumes or white coats and yada, yada. But it doesn't have to be that complicated, especially when we're talking to our patients. We have to say it in a language that they're going to understand, right? So that's really what the book is intended to really convert people's ideas and to hope to influence change that until we start really focusing on not just prevention, but that is important, and wellness and empowering certain communities or power sharing with certain communities, ultimately are the ones that are most afflicted, we're going to continue to see the same thing. And we have, and that's what I hope to demonstrate in the book when I look at about a dozen pandemics starting from 1899 to the present, or 2024 anyways. But ultimately that there's this rubric that I build out. There's these 5 questions that I ask, and I hope the reader basically scores them every time. And if we get to 80% or higher, then we identify that there were indeed social and political determinants or drivers of this pandemic. And had we changed those, we could have ultimately mitigated or even possibly prevented the epidemics, certainly the pandemic. So that's the book. And I think a lot of folks have been discussing it. Obviously, during the COVID-19 pandemic, a lot of people had a lot of time on their hands too. So there was a lot of cogitation and contemplation about what's happening, why are we here, et cetera. But even though the data scientists understood it, we knew that there were certain either representative groups or communities or diseases that are manifest in certain representative groups or communities like obesity, like diabetes, et cetera, like tobacco smoking, et cetera. We knew that those folks were at risk, but why were they at risk? Was it a proxy for something else? And those are the social drivers of health that impact public health outcomes. So that message was just so deeply felt by me. It was just so in my heart that I needed to get that message out. And I try to provide, as a doc, I'm a data-driven person, but I try to tell stories too, because I think especially in this very disinformation space that we have under RFK and whatnot, I think RFK Jr., RFK Sr. was still a pretty good guy.
Wrong RFK.
Well, we need to basically tell more stories now, right? Increasingly, because ultimately people are getting their information from so many different ways. And I don't even know that the evidence matters to a lot of these folks anymore. So I think if we tell them more story, I think it probably has to be a combination of both. I don't saying we got to get away from the data, but the more that we can share some powerful narratives or stories, I think we can help to advise or influence people on different ways of thinking.
Yeah, I do think stories are important and data, but I also agree with you that data is discounted a lot now because people are using stories so powerfully in our media and communication platforms, social media, and you name it. I think it's been really difficult for folks. What do you think I love this framing of the political determinants of health. I think Daniel Dawes wrote about that, expanding the social determinants of health. Do you feel like there's more momentum towards understanding what that means? Because I think as a clinician, you're feeling that with vaccination rates. Now people are saying, no, I'm not going to get the vaccines, and feeling empowered to say that. I know we got to talk about that word in a bit because we keep saying that. But our only tool is to still say they're non-compliant. They're not adherent to recommendation when there's so much more complexity to that. I'm wondering here about a question around political determinants of health, especially here. And what is our role as clinicians in this environment?
Yeah, it's always been there, but it is obviously in the US, which is infecting many parts of the world, it has rapidly accelerated. And the rub is when we even say the term, like we're going to spark debate, right? With other docs or healthcare professionals, and certainly with our patients, right? Because the term itself, which it is a brilliant term, and that's why when I actually was originally going to name the book, The Social and Political Determinants of Pandemics, but that was too academic and too much to put in. So my editors suggested something else, a little bit more alliterative. But it is so difficult to have those conversations. And so on the one hand, they're necessary for us to get to a space where we could almost take back as physicians. I don't like the term control, but take back more accountability or more ability to help influence the outcome of some of these large population health outcomes. And depending on your specialty, my background's infectious diseases. So New York Times did a correlation of specialties and political parties years ago. And psychiatry and infectious diseases had the strongest correlation with being a part of the Democratic Party. And it was mostly surgeons, I think plastic and ortho were the most likely to vote Republican. And that makes sense particularly from a compensation model. And honestly, like my book is intended to really depoliticize public health, right? We can have our different sort of perspectives when it comes to Medicaid coverage, Medicaid for all, et cetera, et cetera. Of course, I believe in it. I think it's a human right. But the book is really focused more on public health, which is obviously not healthcare. They're related, but not healthcare. And, the point that public health really should be depoliticized. Like it is a common good. And just like the fire service or even law enforcement, which is a little bit more controversial, but it is a common good and you cannot take that away, right? There is no controversy when it comes to fire service. Like when fire service is working effectively, houses are not burning down. But when it's not, when you take that away, you understand its power. Same thing with public health. Public health, and I actually used to say this, and I'm going to change this for a second. I used to say public health at best, when it's working most effectively, it actually should be invisible. It's those safeguards or those boundaries around people, protecting them, et cetera. But I actually disagree with that now. I don't think we should be invisible. I think that we should actually speak a lot louder because I don't think a lot of people really understand what public health is and why it's important. And I think they need to understand, a lot of folks will understand the public health nurses, the clinicians, physicians, et cetera, maybe, but they understand that to be TB, maybe HIV, et cetera. I think they really need to understand the epidemiologists. I really think they need to understand the frontline workers, how that's really protecting themselves. Anyways, getting back to your point, which is reason why this is so long is because it is so complicated. I think it's easier to talk about depoliticizing public health. I think it is more difficult to talk about depoliticizing healthcare. And partly because I think they really need to understand the stories. I think this is where more of the stories come into play. And I do think that in a lot of communities, I do think we need to talk about how it could ultimately, if they are more politically conservative, they're like, you know what? I don't want to pay for people that are uninsured. I don't want to pay for these folks. I don't want to pay for Medicaid for these folks. I get that. I understand that. That's a fiscal argument and that's rational. But we can have discussions, right, about that. If we can try to take the politics out of it, that is a rational conversation. We can talk about, okay, I hear you. You don't want your paycheck to contribute to X. But if we don't, and here's where the data matters, you're ultimately going to pay Y. Like that is a very compelling argument. I think when I get into discussions with other healthcare professionals or leaders, I often go to the finances, right? Because it really matters. And ultimately, if we were to invest in a kind of whatever we call a single payer system, Medicare for all, Medicaid for all, ultimately it would save us a heck of a lot of money. We pay the most of any country in the world, right? Our healthcare expenditures are by far the most. We're 2.5 times more than Germany, which is number 2. And yet our outcomes are nowhere close to most of these other OECD countries. In fact, our healthcare outcomes are very much on par with Cuba, which spends about less than 10% of what we're paying, and yet has very, again, arguably even better outcomes than we do. So a lot has to change how we go about it. The other part, the healthcare, is going to take a lot of conversations, and it's going to take trust, right? And so I think in this space, for your listeners here, it's going to take conversation. We have to go across the aisle, and we're so divisive in this current space. Like, people just need to listen, and let's really hear, what are you actually trying to say? What's important to you? And there's this concept that I like explaining. There's this tribal concept in Papua New Guinea where 2 tribal members encounter one another. They're strangers to each other. They have to ask a series of questions to try to connect on some level. And they have to continue to ask. And I think they get 11 or 12 different tries at it, like the 12 degrees of separation. And if they completely strike out at number 12, then they have to challenge themselves to a duel. Because the theory is, if they cannot find anything in common after asking all of these sort of questions, then they have nothing to talk about, and that ultimately they will be enemies, right? But that almost never happens, right? Because ultimately, if you keep peeling the sort of the onion layers of humanity, you will find a connection at some point, whether it's sports or love of certain cuisines or whatever. Like, you will find that connection somehow. And we've got to do more of that, right? And less of the echo chambers, the social media, getting angry at certain folks and whatnot, because we're just not going to get anywhere if that's the case.
Yeah, the algorithms don't do us any benefit. Yeah, I think this idea of digging into what people are actually trying to say, whether that's your interest, not your position, what are your values and emotions, so that the underlying feeling is important. And we're just failing to do that so often these days.
And when it's almost that motivational interviewing that a lot of us as clinicians are taught, right? Like, I really try to do this. I'll say, what I'm hearing you say is this. So how can we get, which we need to really exercise that, not just in the exam room, but when it comes to talking to other communities, leaders, politicians, et cetera.
Yeah. We're in the margins of talking about trust. So want to actually ask you directly. You've worked in so many different communities around the world. And it's actually the hardest to build trust with communities that have been marginalized because systems or structures have mistreated them or ignored them. Have you had a framework or any way of building trust with those communities when you show up? MSF, you've been in so many different roles, but you're showing up almost blind for a short time and trying to build trust.
Totally. Great question. Super hard to do. I work for Indian Health Service. Right now, we're working on a program where we will actually want to expand tribal health access outside of Indian Health Service, and the tribe would own the operation. I was taught or advised by some of my mentors working in the tribal health space when I was there that sometimes it takes years, sometimes 5 to 10 years to build trust, particularly when you're dealing with historical trauma, generational trauma, et cetera. I've spent most of my career focused on some of the most historically marginalized communities, trans non-binary communities, refugees, asylum seekers, obviously Native Americans, et cetera, et cetera. So when the white hetero cis American doc comes into the exam room or whatnot, I've got a lot of making up to do, right? Like, I understand, and I think I understand, that when I'm going into that exam room or when I'm going into that room, that they already don't trust me for so many reasons, for all of those identifiers that I just communicated. Like, they already don't trust me. So I'm working against that. I think I'll do this from 2 angles. From a physician standpoint or clinician standpoint, what's key is trying to find connections, right, with those folks. So I'm always going to do a deep scrub. If it's a new patient, I'm going to do a deep scrub of their background, that H&P, and especially like that social history, I think is really important. And if it's not there, sometimes it's just not captured. A lot of times, for example, language or country of origin or primary language is often not reflected in our EMR systems. We'll do Spanish, or if it's just non-English as a binary, but it's not enough. Like, we need to understand if it's Urdu or Hindi or if it's Portuguese or whatever. And so that cultural background will really help me as a physician leader. I will make sure that any community health center or operation that we have will have a lot of language or identifiers that makes people feel welcomed, as inclusive as we possibly can. I try to put on as many like stickers or pins. I've got these identifiers that says refugees welcome. So then when I walk into rooms on my lanyard, and this is actually a little barren, usually I'm like tatted down with emblematic, inclusive sort of stickers. So that's one way that I say, hey, I'm friendly, right? The second is I won't wear a white coat, right? I try to be as relatable as possible. And then culturally, I speak 6 languages and I know hellos or some foods or whatever in dozens, and it's traveled quite a bit. So I try to use that too to break some of the ice. And the minute that I'll say like a hello or a salam, they get it. And they're so like mystified. Why is the white guy like talking like this? And then I'll talk to them about some food or something like that. And it often, not always, but it often just disarms them. If it's I work a lot with trans communities, this helps a little bit, but really being like expressing cultural humility is super important. And so I'll talk to them quite a bit about that. So that helps from a physician standpoint. As a leader, what I really try to do is I try to have my team be as representative and diverse and inclusive as possible, because that matters a lot. Trusted messengers are key, right? So community health workers are a workforce that I think have been forgotten for decades in the US anyways. They have been an essential workforce in many other countries like South Africa, but I really try to keep my team as diverse and representative as possible. Again, particularly community health workers, so those communities have that level of trust. So street medicine, for example, we try to keep people with lived experience on our team so that they can relate to folks. And then when they see the doctor, it's okay. Like, I trust you as a group. Like, I trust this is our emblem, like Wellness Equity Alliance. And it's like when I used to work for MSF, Doctors Without Borders, Médecins Sans Frontières, they're brilliant at that, right? Like, they have created a brand. I used to hate that term, but now I'm okay with it. They have created a brand where people see an image and they correlate trust with it. Like, they know that they're the good guys. And that's what we're trying to do we have these trucks and we have our emblems, our logos, and everybody's wearing the t-shirts or the hats. And like, they know that, okay, this is not, especially in today's space after the Grants Pass decision, when law enforcement is really locking up a lot of homeless people for being homeless. Think about that, right? Folks, they're just naturally distrustful, and they've already dealt with generations of trauma their entire lives, average childhood events or encounters, experiences as well, seeding that. So to make matters worse, now they've got folks, sometimes they're plainclothes or whatever, that are coming out there to disrupt their current lifestyle. So we have to work harder at that. And the MSF reference, when I first started, I interned with them in the early 2000s. And I was in Rwanda and I saw this little popsicle. It was a little truck made of popsicle sticks. And it had the logo, the MSF Doctors Without Borders logo on it. And they were naturally selling it. But what I thought when he was presenting it, I distinctly remember, this was like 25 years ago. They were so proud. They were like, it was happy. This was a happy token to them. And I was like, man, that's cool. This is like one of the darkest moments of time during the 94 genocide. And less than 10 years later, they had this beacon of hope, and it was in the form of this popsicle stick, no resources, this popsicle stick truck. And I was like, man, that's cool, right? Like, when I grow up, like, I want to build something like that. So hopefully we're doing something like that in a somewhat different scale.
That's incredible. We've talked about a lot of topics, and I want to note your call out for branding, because I feel the same way. But it's become even more important to acknowledge the positive sides of branding, because sometimes branding seems performative, maybe, of this is what we seek to be, but it helps to build trust in telling people, hey, these are our values, this is what we believe in, so people can have at least a shortcut for trust, because it's so hard to know. And Doctors Without Borders have built that. Is there any takeaway for people that you want to leave them with? And then where can we find you and your book?
Yeah, I think the takeaways are, look, at this point now, health systems, public health are under attack, right? Let's not try to avoid that reality, right? It is happening. When I wrote the book, Pandemics, Poverty, and Politics, which you can get on Amazon, Barnes & Noble, it was published by Johns Hopkins University Press. When I wrote this, the message was, okay, folks, we have to depoliticize public health. Let's keep the politics out of it. But at this point, it's very clear that the politics are a lot of what is dismantling public health and healthcare. And it's not a blue and red thing. So we need to be clear about that. This is not that. This is for healthcare professionals that are out there. This is not good. This is not evidence-based. This is not science speaking. Like, our actually bringing on a new member of our team, Dr. Dimitri Daskalakis, who's He was like the number 3 at the CDC. He was the chief of the National Center for Immunizations and Respiratory Disease. And him and Deb Howery and a few others famously resigned. And they tell the story that basically there are no scientist leaders in the CDC right now. That's by design. Nothing, zero. They're all political appointees. And it's not just the CDC has often been the sort of proxy of, federal scientists. It's not just the CDC. There are a number of other healthcare agencies that are out there, and they're under attack. That is the goal. The goal is to just destroy and dismantle. And so we have to fight back, right? We have to fight back, and we have to do it, though, in thoughtful ways, right? I'm not saying that political rallies are not effective, but what I am saying is we have to think a little bit more elegantly and a little bit more creatively about how we can respond to a lot of these pieces. Yes, writing to our congressmen or congresswomen, getting out there on your social media, talking to your communities, that all helps, but it's not enough. We've got to do more than just talk, right? So for healthcare professionals that are either frustrated or that believe that we're going in the wrong direction with this, or we have been going in the wrong direction for decades and this is just accelerating it, we have to band together and we have to really think creatively and innovatively about how we can do more, how we can get at least a third of the United States patients do not or cannot engage in healthcare in the way that it's currently set up. Okay. There's good evidence for that. UCSF just came out with a study in 2024. We have to think differently, right? And we are under attack. So there's a lot of external threats out there that are going against us. But what I would really suggest to your listeners is to think about how the finance, the politics, the operational efficiencies can all be leveraged to ultimately help our patients and to get healthier. And whether you voted with the blue card or the red card, it doesn't matter, right? What's matter is what's important to your patients and to the communities that are at risk. And so we have to do better. We have to come together. We have to talk to tech. We have to talk to finance. We have to really think differently, and we have to rebuild, because a lot of this stuff, it's gone, right? Like CID and all this stuff is gone. And I do think there's a rebuilding. There's no preservation for a lot of these pieces, but I do think that there's a rebuilding, and it's going to have to be a radical rebuild, which is okay. It's a big problem, but it's an okay problem to have. So we really need to band together. All healthcare professionals really need to band together. Blue, red, purple, magenta, whatever. We need to band together and think through how we can rebuild these systems. Man, because it matters, right? Like we train for decades to decades. I trained for a long time. And all of that knowledge and all that content, it's just getting lost, right? If in this maelstrom of medicine that we're currently practicing. So we've got to rebuild, and we have to look at other models that are effective. You don't have to reinvent the wheel here. There's a lot of other models out there across the world that are very effective, and we need to piece that together. So there's a lot of good thought leaders that are thinking through this space. So the call to action is we got to band together, think through these different sort of concepts and ideas, and think how we can really rebuild in solidarity with what we were trained to do, which was to be healers for our communities.
Love it. Thank you for that pep talk and really inspiring message. I think it's needed in having a joint identity as healthcare professionals and a shared purpose, because it's true. And I want to channel your internal optimistic that we can do it. And it's hard feeling that way, but holding on to that hope is important. Thanks, Dr. Evans.
Yeah, good. Great being with you.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized, topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.